Hello everyone, it's Danny here. Today we're going to talk about ECG abnormalities in adults in a nutshell. If you need a reminder of the elements that make up an ECG, please pause here and take a look at the video I posted last week on ECG basics. Then come back, there's plenty of time. Before diving right into this, I must stress what is considered technically an abnormal ECG may be entirely normal for the patient in question. For example, the ECG of a patient who has a pacemaker is technically not normal, although the patient may have been living with a paced heart for years. Also, there are normal variants. ECGs may appear abnormal, but they are indeed normal in the patient-specific context. We can broadly speak of our ECG headaches as abnormalities of segments and intervals, abnormalities of rate, rhythm, morphology, and the relationship of ECG elements relative to each other. But first, let's revise our 12 leads. There are 6 limb leads and 6 precordial or chest leads. Each set of leads looks at the heart from a different angle. As such, we can broadly divide the leads into inferior, anterior, and lateral. If you need to memorize these, pause here and move on when ready. First, ST elevations. To suggest a heart attack, ST elevations must be seen in at least 2 contiguous leads, inferior, anterior, or lateral. Except in limb leads, you would need 1 millimeter or more elevation, but in chest leads, you would need at least 2 millimeters. Here is an example of an inferior STEMI. This one here is an anterior STEMI. And here, of course, you can see a lateral ST elevation MI. ST segment depressions are equally significant. In fact, we often see reciprocal ST depressions in patients with ST elevation MIs. But even in the absence of ST elevation, any amount of ST depression in a patient who has chest pain is of significance. Now, let's remind ourselves of T-wave abnormalities. T-waves are normally positive. Flipped or negative T-waves could suggest ischemia in a patient who's got chest pain. Tall and pointy T-waves could be a sign of hyperkalemia or high potassium levels. Asymmetrically peaked or so-called hyperacute T-waves are seen in early stages of ST elevation MIs. Next, let's talk about abnormalities of rate, rhythm, and QRS width. Too fast or extremely tachycardic is abnormal, especially if the patient appears compromised. The signs of compromise are chest pain, shortness of breath, and reduced GCS. Always flag a tachycardic patient's ECG fast. Too slow or extremely bradycardic is not normal either. Although an athlete who runs 1,000 kilometers a day may have a heart rate of 38, and that may be entirely normal for them. Again, too slow, especially in presence of signs of compromise, is abnormal. Get the patient seen pronto. Too wide is not normal. Remember, the normal QRS width is about 2.5 small squares. Conduction defects, metabolic derangements, and, of course, pacemakers broaden your QRS complex. Examples of conduction defects include bundle branch blocks, right or left. Metabolic derangements like hyperkalemia could also widen your QRS complexes and kill your patients. And I'm sure you're familiar with the pacemaker spikes and the wide QRS complexes that follow them. With the advance of pacemaker technology, the spikes have become more subtle each day, and finding them has become a headache. That said, some pacemakers work only on demand. They kick in only when required. Moving on from rate in this fast-paced video, the heart is meant to have a regular rhythm. Irregularity is not normal. The rhythm can sometimes get totally chaotic, irregular, like in atrial fibrillation. Or you could find some pattern to its chaos, in which case it's called regularly irregular, like in this ECG, in which the PR intervals increase gradually until a beat or a QRS complex drops. And this pattern is seen regularly throughout the ECG. This is called a second-degree heart block. We talked about widening of the QRS complex earlier. P waves could also look abnormal. They could be too large, inverted, bifid, or of varying morphology. Each of these signifies a certain pathology, usually originating from the atria. The PR interval, the time from the onset of the P wave to the start of the QRS complex, is normally 3 to 5 small squares. If it's persistently longer, it is called first-degree heart block. If it is gradually prolonged until a beat or QRS complex drops, that's a second-degree block type 1. Type 2 second-degree block is where the PR intervals are not gradually prolonged. Instead, they randomly fail to produce a heartbeat or QRS complex. There may be no pattern or predictability to this chaos, which is not good at all. By the way, second-degree blocks are also known as MOBITs. So you could have MOBITs type 1 or 2. Type 1, the gradual PR prolongation until you lose a beat, is also known as Wenckebach, strictly nomenclature. The next important abnormality is the dissociation of P wave and QRS complexes. Normally, every P wave is followed by a QRS complex. However, if there are regularly occurring P waves and regularly occurring QRS complexes, but they are not linked, each is doing their own thing at their own rate, that's not normal. This is called atrioventricular dissociation, also known as third-degree or complete heart block. These patients may be extremely bradycardic and require admission for pacing. And finally, let's take a look at the abnormality known as prolongation of the QT interval. The QT interval is the time from the start of the Q wave to the end of the T wave. The ECG machine produces a value called the QTC, or corrected QT interval, which is the number to use, so you won't have to count the small squares. Extreme prolongation of the QT interval could have catastrophic consequences. QTC is prolonged if it is more than 440 milliseconds in men or more than 460 milliseconds in women. As a rule of thumb, a normal QT interval must be less than half the distance between the two preceding R waves. In other words, your T wave must end before reaching half the distance between the preceding R wave and the next. I think that's enough ECG abnormalities for now. Just a brief overview. I will leave a link to the summary of this talk in the description below. Stay safe, and thank you for watching.